So I didn't add it in here because I thought it was going to be boring, but it's very important to know that the pelvic floor is made of the same two type of fibers, which is type 1 and type 2. The difference being the majority of the fibers, somewhere close to 50 to 70% are type 1, which are fibers which are for endurance or holding capacity. That's why they're able to hold the weight of the 3 pelvic organs. And type 2 fibers are the sphincteric fibers. So the type 2 fibers are the ones which control the urethral sphincter or the rectal sphincter. They form anywhere between 5 to 20% depending on the person. So we therapists love our anatomy, and as sir was telling, we do focus on the innervations and the muscles also. I'm not going to give you an anatomy lesson today, but just to give you a view of our perception when we assess a patient. We are looking not just at the levator ani, we are looking at all the pelvic muscles and the ancillary muscles around it. That the levator ani is the puborectalis, pubococcygeus, iliococcygeus. The coccygeus is not a levator ani, but we do consider it a lot in pelvic floor rehab. And going into the layers, I've used a female model just because it's more descriptive. So when we do a PR or a PV, our palpation of muscles is very different. We use a clock. It's called an A clock. So we go according to quadrants, 1 o'clock, 2 o'clock, 3 o'clock, 4 o'clock. So when we are assessing muscle strength, we actually look at individual muscle strength. We look at symmetry, whether one side is stronger, one side is weaker. We are looking at the pressure. I'll show a slide which shows how the difference is. But we are also looking at the soft tissue. So sometimes what we think is a muscle might not be a muscle. It could be a perineal descent. So we are looking at the bony landmarks also. So bony landmarks for us are very important because we do a lot of musculoskeletal work. So we base our treatment on the bony landmarks. And this is the deeper layer of the pelvic floor. Here you can see if we have to do a PR, so that would where it would be, which gives us a really clear access to the puborectalis and the external sphincter. Also to be noted is we can access the piriformis and the obturator muscle on the sides. Why these are significant, we'll come to it when we're talking about posture or breathing or defecation. Everything is controlled by those muscles. So when you think pelvic floor, please just don't think about the levator ani or the sphincters. Please think about all the muscles in and around the rectal and the vaginal canals. This Dr. Rupali did go over as what the pelvic floor does: bladder and bowel control, pelvic organ support, the sphincteric function, sexual function, breathing, pregnancy, and childbirth. Like I said, this is how we visualize the pelvic floor with the sling muscles around it. But also, very importantly, pelvic floor is a stabilizing muscle. For us, I mean, as a gastroenterologist, it's an evacuating muscle, but it forms the stabilizing part of our core. So abdomen, lateral abdominal wall, back muscles, and the pelvic floor together form one system. So it's never actually activated or working individually. It always works in synergy with the rest of these muscles. I'm going to skip this one. So as a therapist, when does a gastroenterologist or a colorectal surgeon think about us? In my practice, we also do a lot of urogynec and urinary work, but this being a CME with gastros and colorectal surgeons, the common referrals we get are functional fecal incontinence, alorectal pain, proctalgias, levator ani syndrome, unspecified anorectal pains. Functional defecatory disorders is our bread and butter because those are the most prescribed. So that's dysynergic defecation and inadequate defecatory propulsion or slow motility constipation. So how do I look at this, classifying it even more? Is types of functional constipation, like we said, dysynergic defecation, slow transit, colonic. So we send out these flyers to consultants in case they don't realize at what point do we give it to a therapist before we either go into surgery or we are going into, further laxative use. So how else do we see it? Anismus, pelvic floor dyssynergia, obstructed defecation, paradoxical puborectalis contraction, non-relaxing puborectalis, pelvic outlet obstruction, and spastic pelvic floor. I'm not going to dwell into what are the neurological causes or if it's an upper motor, lower motor, but when you hear these diagnoses, please think that if there is a pelvic floor involvement, there is a role for a pelvic floor therapist here. And I'm skipping to the bladder functions, but I think I can skip the whole thing. So Dr. Rupali covered this, so I'm going to quickly go through it. But when you see a paradoxical external anal sphincter or puborectalis contraction, involuntary anal spasm, or inadequate anal relaxation, inadequate puborectalis, or impaired abdominal or rectal pushing, this is when you think about a physical therapist or that this person needs a correction. This can be either seen by a simple rectal examination, or you could do this in an anal manometry, or a diagnostic biofeedback can also give you the same results. So what are the common symptoms when you see this? Is excessive straining, abdominal bloating, passage of stools being hard, less bowel movements per week, digital maneuvers as disimpaction, that is digital evacuation, vaginal splinting, feeling of incomplete evacuation, which is the most common complaint we see. And what are the associated symptoms? So it's never a single symptom of constipation. I think it's the other way around. Usually abroad when we practice, they come to the physical therapy first. So we try to do as much and then we refer. But by the time they come to us, everything is like a mixed bag of masala for us. So they also have urinary symptoms, they have sexual symptoms, they have low back aches, and a lot of pelvic pain, which does not have a simple diagnosis. So again, this being a gastro conference, I'm not going to coach you on what other symptoms there are. But when you're looking at muscles, we also look at something called perineal descent. This might or might not be picked up in the defecography, like Sir had mentioned, because it depends on the squatting position. If you were able to squat better, the perineal descent is more apparent. But if you're not squatting, you do not actually pick it up in a radiograph. But when you ask the patient, when a physical therapist is examining a patient and we ask them to create intrarectal pressure versus intra-abdominal pressure, you can see the perineal muscles actually try to come outwards. We are not only looking at the sphincter, but we are looking at the connections of all of them from the ischial tuberosities to the perineum. We see this definitely more in obstetric traumas or, women who are postmenopausal, but chronic constipation also causes ballooning of the perineum. So the patient, how this is significant is we are constantly teaching the patient how to evacuate through the sphincter. But the patient cannot create pressure in the sphincter because the abdominal pressure is being dissipated throughout the pelvic floor. He's pushing the whole pelvic floor down, female or male. So to isolate it in the rectum becomes very hard for the patient. I'm going to skip this one because it was covered before. So this is a chart I use for anal incontinence, but the same goes for dyssynergic defecation and disorders also. When do you refer them to the therapist? So the primary physician or the gastroenterologist, whoever is seeing them, if they feel this is more of a musculoskeletal, with your history taking, you realize it's more of a musculoskeletal disorder, please do give it a try, referring it to physiotherapy. And what do we do in physiotherapy? I shall cover it in detail. And there is always a cross-referral system. Like I said, we are a small cog in the wheel. We cannot rule out a lot of, differential diagnosis. So most of the times when the patients are sent to us, the differential diagnosis is already done because we do not deal with organic causes of constipation. But once all these scans are done, and then you still realize, okay, we can't actually put our finger on this and this is more of a neuromuscular problem, then the referral comes back to us and back and forth. And how does a physical therapy examination work? I actually trained as a musculoskeletal therapist. So we are very thorough in how we take history and how we check, but we also do a Bristol stool scale. We do a bowel diary. We do a very thorough pelvic floor assessment, abdominal assessment, and our squeeze pressure. So because we do not use diagnostic biofeedback, if I have a manometry in front of me or a defecography, I'm a lucky girl. But if I don't have them, it is very subjective because if I check and the other therapist checks, definitely there's a difference, but we have our own grading system. I'll go through it. It's called a perfecta score as to how I assess. But for example, when I'm saying the patient's push pressure, but I also always note that the push is an intra-abdominal push versus an intra-rectal push. Or if I'm talking about squeeze, I will say, is it a squeeze of the sphincter, or is the patient using his adductors to squeeze? So the patient is actually not squeezing, properly, he's using his ancillary muscles. And just like Dr. Ripali was saying, a resting tone, maximum contraction, hold time, and how many repetitions the patient is doing. Initially, we would just do a modified Oxford scale, which is 1, 2, 3, 4, 5 for any muscle. We do that for any skeletal muscle. But for pelvic floor, it is different. When we do it in different settings also. In rest, we look at it, we ask the patient to cough or sneeze, and we ask the patient to bear down. So the testing is done in various positions. So we check for the power of the muscle, the endurance, the number of times each contraction is repeated, how fast or slow they can do it, if there is a perineal elevation. So the levator, we call it a levator lift. So can they actually not just squeeze, but also elevate the whole pelvic floor? Are there any co-contractions of the muscles around it? And what is the time they can finish 20 repetitions? And can they voluntarily relax after the contraction? So what are the goals of pelvic floor training in defecatory disorders? To optimize the stool consistency, to normalize the urge, normalize frequency and defecation. And what exactly is pelvic floor muscle training? I will simplify it because it's, like I said, quite boring if we get into the details. We are optimizing the exit. We are optimizing the exit of the stool. And we are working on the pelvic floor muscle, the puborectalis, and the external anal sphincter individually. We work on the proprioception and normalize the rectal sensation and management of rectal compliance and capacity. So we were talking in the beginning about type 1 and type 2 fibers. So putting biofeedback aside, which is a great tool, sometimes what happens is innervation is not intact or the muscle has lost its elasticity. So when we are dealing with muscles which are not as compliant as a regular skeletal muscle, you do not get the same feedback as a stronger muscle. So we look at type 1 separately and type 2. So rehabilitation for type 1 is more of a slow contract and more of a hold, whereas for a type 2 fiber, where the patient is not able to generate pressure, it is more fast contractions. The number of contractions and rest periods are smaller. Some of the referrals we get from the surgeons are rectal prolapse, mucosal interceptions, solitary rectal ulcers, rectocele, enteroceles, and descending perineum syndromes. So I'm not great with classification here, but usually anything they've said that probably is not going to be operated and they want to do a conservative management ends up at our table. But once in a while, before going for surgery, they ask for a prehabilitation. So they realize the muscles are weak to start with. So the outcome of the surgery is definitely better. You strengthen the pelvic floor muscles and then go in for surgery. Definitely the chances of recurrence is much lesser. And how do we start up physical therapy management? Lots and lots and lots of patient education. First, making the patient understand the baseline, because there's never a normal baseline for anybody. So if this patient has dyssynergic defecation type 1, 2, 3, 4, or any kind of pain, the baseline has to be understood and the goals have to be set initially, because patient compliance is everything in rehabilitation. And our referral doctors are so great because they are picking the right patient. If the patient is resisting to therapy, it is not easy because it takes us a long time to bring in compliance. We start with defecatory mechanics. This was gone through before also. The difference I would like to tell how physical therapy helps this. Let us say the patient has tight hip flexors, or he has back pain, or the patient is training and he's not able to get enough air. This is where physiotherapy comes to help. We release the diaphragm. We actually work on diaphragmatic muscles. So the patient is not able to take a deep breath. We will release the abdomen. We will check for the expiratory capacity. It just takes one session. Or the patient will say, I'm sitting and my tailbone hurts. So a small manipulation of the tailbone, so that because probably the puborectalis was pulling too hard on the coccyx, and the patient automatically associates pain with defecation and there is more dyssynergia. So we also teach pushing strategies, manual perineal support if needed for a lot of gynac patients, and abdominal massage and pelvic floor muscle individual rehabilitation. So this is the example of something we call I love you massage. It's the ILU massage. So it's a specific technique. I mean, I think my grandma probably did a better job of it, but so we teach the patient, we first put a hot compress for about 15-20 minutes, and we start teaching them circular massage techniques with their own hands. So we make them do this once at night, once post meal, and once when they feel the urge. We ask them to kind of calm down. And here I'm talking about dysynergic defecation. This is obviously not for people who have diarrhea or incontinence, but this is the first I don't know if I have a pointer, but that's the I and the L and the U. And we do it around 20 times. So you could use, my grandma told me to use sesame oil, but any oil which is non-irritant to the patient, and you warm it a little bit after a hot compress, that definitely helps a lot. We also went through the pelvic floor strengthening and relaxation exercises. The difference between strengthening and relaxation. So when we say Kegels, people just assume that the pelvic floor always has to be strengthened. But if you're having a very tight pelvic floor, relaxation comes first. So relaxation of the sphincter is hard. We will talk about it, but the relaxation of the muscles around the pelvis is quite easy. So you open up the abdominal muscles, open up the side, oblique muscles, open up the back, open up your diaphragm. The pelvic floor automatically relaxes because there is a synergy in the movement of the pelvic floor with the diaphragm. As the diaphragm goes up, the pelvic floor goes up. The diaphragm comes down, pelvic floor comes down. If there is enough synergy, so automatically in a minute, there are 12 pelvic floor contractions as it is. So strengthening is not as important as relaxation of the pelvic floor. We also do something called Jacobson's relaxation. We've gone through the breathing exercise, so I'll focus on the Jacobson's relaxation. It's a technique which is taught to us very early on. We use it for a lot of muscle spasms. So we go through muscles from the top of your head to the tip of your toe. We are teaching people to contract and relax. Contract, relax. We put them in a very quiet room. We turn all the lights off and we try to put some calming music, and we get the person to focus on every single muscle contraction and relaxation. Because these are the people who are unable to relax their pelvic floor. The muscle is already tight, so they cannot isolate it. But as a co-contraction around it is happening, the patient slowly understands that the pelvic floor can be also relaxed. So when done every day, it's a very simple thing. You can go to YouTube, Google Jacobson's or progressive muscle relaxation. It works like a charm. Like, it also brings down anxiety. The patient's pain comes down. Also, patient slowly realizes that he was clenching his pelvic floor while defecating, and now he knows the difference between the clench and the relax. And breathing exercise, diaphragmatic breathing, abdominal breathing, two very different things. A lot of people think that abdominal pressure or abdominal push is very important. It's the actual opposite. The patient first needs to understand the thoracic breathing or diaphragmatic breathing. The pressure builds up in the thorax, abdomen will expand automatically. And defecatory mechanisms, again, I'm not going to stress on, but when we are working with certain muscles and we realize that there is more of a perineal pressure and not rectal pressure, we will try to work on the ancillary muscles to make them tighter and only focus on the rectum. How successful? I have evidence, I didn't add on it, but I'll be happy to share it. So overall success is 70 to 80% for functional defecatory disorders. That's by Dr. Rao also. And healthy function of the pelvic floor muscles will result in a stronger urge to defecate. This is where a lot of people don't think that, when you're only thinking of dyssynergia, but on overall healthy pelvic floor for a woman, let's say post-menopause, we refer to the gynac to say that does she have atrophic vaginitis. So first we address the pelvic floor health overall before we start treatment. And up training and down training. So these two words are important for the other therapists in the meeting, is because not every pelvic floor needs to be strengthened. It also has to be relaxed, and not every tight pelvic floor is strong. Sometimes when we release the pelvic floor, you realize it is actually very weak now, and then the strengthening starts. And very important, transverse abdominis. This is one of the most important muscles in defecation. So a lot of trigger points tend to be in it, lot of dysfunctional. Sometimes you don't even activate the muscle when you're trying to defecate. You're using all kinds of wrong muscles, and no wonder there is so much pain. So we try to strengthen the transverse abdominis and proper body mechanics. So this is a topic for another day, but I'll touch on it briefly. We use a lot of transcutaneous electrical nerve stimulation. Like I said, if it is a non-functional pelvic floor, that means there is zero. The strength on the pelvic floor is zero or like a +1. It is not even a flicker of a contraction. We start electrical stimulation. So the type 1 fibers are different. So we will use a different electrical stimulation. Type 2 fibers, different electrical stimulation. And sometimes we use, if it is an urge, we are using at an S1, S2. So we use probes at the S1, S2 or the posterior tibial, which is on the bottom of the malleoli. And if the patient is dysenergic, they've figured everything out, but they're still struggling because it's a learned habit to keep straining. The pelvic floor is relaxed, but the patient is still trying to push. We will try electrical stimulation at the abdomen also. Other things we do for constipation or any pelvic floor disorders are scar mobilization and myofascial work. So a cesarean scar, which probably caused the patient not to have enough push pressure, can be mobilized. An episiotomy scar or an old, any kind of trauma scars, any adherent scars, deep lacerations, myofascial pains. Ultrasound is something we use in a regular practice that can be used on, rectal pains also. Good posture is everything. Mechanically, the patient is more efficient when all your muscles are working in its optimum position. And we also do a lot of balance work because proprioception is a part of your physiology which kind of triggers every other physiological reaction. So, and joint mobilization. So coccyx, sacroiliac joint, and good lumbar movements. So I'm going to skip biofeedback because we've gone through biofeedback. The difference. So when we do the difference between the pressure feedback, which Dr. Rupali does, and the feedback we do, is we don't have as many normative values because ours is an electrical biofeedback. All we are picking up is electrical potential. We don't have the same numbers for the squeeze pressures, but we see the electrical potential of each muscle. So my probe has two receptors, and one we can put it at this external sphincter, one at the internal, or you can manipulate it to put it whichever way, whichever muscle I think needs to, be rehabilitated. But what I'm looking at is the maximum contraction, is the duration of the contraction, and the relaxation. Can the patient relax voluntarily, or is the patient taking a very long time to relax? These are the same parameters which we use to rehabilitate the patient also. When we are doing 5 or 6 sessions, so the first session to the second session, I need to see a change in these parameters. And how does a changed parameter look? So when you can see group one, the difference to give you is the maximum contraction. So the squeeze pressure or the pressure of the pelvic floor, they're not able to create. It could also be that the number of fibers are not being used. It could be less number of fibers, so the strength is not good enough. In the second one, there's a lot of noise in the bottom. So that means it's not relaxing. So the patient has contracted, but the relaxation is not good enough. It is not going to baseline again. So once after treatment, group 1, you can see this was up training. So the patient, we are trying to make the pelvic floor stronger. So the contraction has become higher. In group 2, we were working on relaxation. So that means the patient can contract on will and relax on will. There is no ancillary movement. There is no extra movement of the pelvic floor. So this was also covered by the biofeedback therapy. This is how we base our treatment sessions on, how many times, but it's very fluid because all these patients don't usually come with one symptom. There's a lot of cognitive behavioral therapy we do also because these are learned habits. Defecation, by the time they come to us, it's a learned habit, and there's a lot of anxiety when we try to change their habits. The muscle will listen to me, but the patient will not. So when I'm working with the consultant also, and I ask them, so laxative at this point is comforting, even if it doesn't work. You're working with a stool 4 or 5, but the patient still wants to strain. So they want to sit in the bathroom for 30 minutes. There's a cleanliness obsession. So all of this, when we encounter at some point, we will refer it to a psychologist. And in conclusion, so biofeedback therapy, pelvic floor muscle rehabilitation put together actually work really well for constipation and defecatory disorders. And there's a lot of evidence which shows that just biofeedback versus biofeedback plus rehab plus a lot of CBT together brings out a lot more efficacy. And that's my friend Susie, who's trying to do her pelvic floor rehab by opening a wine bottle. And thank you. I'll take any questions after.